feel free to unmute yourself if Dr. Kloster opens the floor. For those requesting CE or certificate of completion, we will share an evaluation link in the chat towards the end of the presentation. To receive a certificate, you must attend the full presentation. Also, please note that you will have 48 hours to complete the survey before it becomes inactive. Without further delay, I hand it over to Dr. Kloster. Thank you very much again.
Hey, hello, everybody. My name is Dr. Kloster. I'm a psychiatric resident here at University of New Mexico, currently on my community psychiatry rotation, presenting today on involuntary psychiatric treatment, some of its history, the context, and the challenges we face with psychiatric involuntary treatment, specifically here in New Mexico. Just briefly, kind of to go over how to fill out your CE certificates, some disclosures before we get started. I don't have any financial arrangements or any disclosures to release about the information in this activity, and the views in this presentation are of my own and do not necessarily represent the views and policies and positions of the University of New Mexico. So briefly to start out with, kind of reasoning for my topic and wanting to kind of share with community providers is that kind of the role of mental health providers is to assess patients, and specifically patients with severe mental illness, and bring them into a psychiatric facility if we feel that they're sort of meeting criteria for an emergent psychiatric evaluation. Essentially, this aims of this project is to kind of show what happens when a patient shows up specifically at the Psychiatric Emergency Center at UNM, and kind of how we think about admitting and discharge and when involuntary hospitalization is warranted, and what kind of challenges and consequences we faced from a historical context, from a context of looking at New Mexico in of itself and our lack of resources, and sort of what ethical and moral issues we face when we want to treat somebody against their will. I also wanted kind of to briefly speak on patients who suffer from severe mental illness and sort of the population that experiences homelessness from that, and what other states are trying to do and pushing towards more admissions, when I think our evidence typically shows that we need to move more towards aftercare, more accessibility to wraparound services, and then permanent supportive housing. So we'll kind of discuss all of those things. Broke it up into a few objectives. I sort of asked myself, where are we coming from in terms of involuntary psychiatric admission, where we are now, specifically in the state of New Mexico, and then what are the consequences of these policies and where are we going? So you can see here kind of like identifying historical and political context, interpreting New Mexico psychiatric hold criteria, and the consequences and the challenges we face here in New Mexico. So briefly, I'm going to take like we could really dissect this for quite a while. So I'm going to take like as opposed to maybe 20,000 feet, maybe like a 10,000 feet overview of sort of where hospitalization has really come from in this country. The first evidence ever of a mental health facility is in 1403, and it was London's Bedlam Hospital. And definitely took me too long as a psychiatrist to learn that when people refer to something as Bedlam, they're referring to something as madness. And I guess this is the historical context of that. So we can kind of see, I just drew a couple pictures, grabbed a couple pictures from the internet. You can kind of see that what the place looked like in 1676. And then what I thought was actually really interesting and kind of challenging was that at the entrance of the hospital, they have these statues that represent sort of the two sides of what they considered mental illness, melancholy and raving. Obviously, you know, conditions were quite poor, and we'll go into that. Prior to even Bedlam, most of the folks with severe mental illness were relegated to prisons and shelters for the poor, essentially warehoused, and basically to assure safety of the community, and they weren't really offered any sort of type of treatment. Challenge for the group and for everybody that we've come very, very far, but sometimes that sort of sounds familiar, and we'll kind of dissect that a little bit more too. Specifically here in the United States, 4 privately funded asylums were established in Connecticut, New York, Massachusetts, and Pennsylvania, and then other states soon followed. Typically, what the patients had when they came into a facility were diagnoses of dementia, seizure disorder, paralysis, or advanced neurosyphilis. Treatment involved restraint, sedation, and medications like bromides and chloral hydrates, which were very dangerous. No real understanding of sort of the conditions that were brought in. This investigative journalist, Albert Deutsch, I don't know if I'm pronouncing that correctly, but essentially investigated the asylum system here in the United States in 1948, and he kind of titled his investigation "The Shame of the States." He said people with severe mental illness essentially were languished onto the filthy backwards of public mental hospitals. There were buildings swarming with naked humans herded like cattle, pervaded by a fetid odor so heavy, so nauseating that the stench seemed to have almost a physical existence of its own. And we can kind of see the conditions that patients were held in from that picture over there. Institutionalization sort of prevailed in America and really reached its peak in the 1950s. At that time, societal views were very much based on the fact that there was really no voluntary psychiatric hospitalization. All admissions were strictly involuntary and on the parens patriae for government causes, which is a Latin term for, for the community. Essentially, the government sort of saw this as a social responsibility to take people suffering from mental illness away from society for public safety. Peak asylum sort of reached around 559,000 in 1953. Pulled a little clip from One Flew Over the Cuckoo's Nest, which was made in 1975, but it was a period piece sort of about the peak of sort of this asylum culture in the United States in the 1950s. Things started to begin to change in the 60s, though. I pulled a couple things that I thought were interesting, and these are sort of when we get to the 60s, we get towards more deinstitutionalization, but stuff that kind of led up to our ideas of moving away from institutions were a few things that I noted. There's the case of Elizabeth Packard. This was sort of the first case where the idea of policy change needed to come into effect for inpatient involuntary psychiatric hospitalization. At one point, family could purchase confinement for unwanted relatives. So Elizabeth Packard's husband, who is a Methodist clergyman, reported that Elizabeth had an unclean spirit and moral insanity for sort of moving away from the Methodist Church. So she was essentially confined to an institution for 3 years. She would continuously reach out and sue the system, saying that she was sane. And after 3 years, she was finally declared sane and released. When she returned, she had lost her property and the custody of her children. So she dedicated her life after that towards moving away from the institutionalization model. In 1951, there was the NIMH, which is the National Institute of Mental Health. They essentially made this new rule about restoring psychiatrist decisions about civil commitment. Prior to that, when somebody was committed, it was still part of a psychiatric decision, but it was really bogged down in a lot of paperwork, legal work. And this gave more freedom to the psychiatrist, which is a double-edged sword, because I think psychiatrists then admitted, but it also helped for cases like Elizabeth Packard for her to be declared sane kind of more efficiently, regardless, it still took her 3 years. And then in 1950, the first treatment for psychosis sort of hit the market, and it was chlorpromazine or Thorazine, which is its brand name. And this started to show a promise in treatment. We were able to take the positive symptoms of schizophrenia, like delusions and hallucinations and treat them. And patients started to begin to show improvement. So the possibility of staying out of the hospital became more and more clear. In the 1960s, we sort of met the deinstitutionalization, is what I'm going to refer to it as the period. And then it was largely due to a lot of other social and political changes. We can kind of see here, this is a screen grab from a very good book about healthcare policy called Better But Not Well. It's from my phone. I took a picture of it. It's essentially showing the residents in state and county mental hospitals and from 1950 to 1994. And you can kind of see in the 60s is when we really started to rapidly sort of decline in attendance or admissions to these hospitals. The deinstitutionalized period, again, we're going to kind of call it, the 60s. A couple things that, really changed the aspect of these hospitalizations was that Medicaid was created in 1965, and it took part in a large amount of the payments for these individuals that were kind of suffering from these mental health disorders outside of the hospital. Americans started to believe that the cost of caring for the mentally ill in institutions wasn't worth the limited benefit they could see. We had the civil rights movement, which was gaining momentum in the United States at the time, which led to the public push for the abandonment of mental institution in favor of humane psychiatric care, equity, equality, to look at, kind of power structures was very, very important. And we can even go into a deeper conversation at a different time or in a different presentation about the DSM-5 and psychiatric conditions and diagnoses that were kind of laid upon the grounds of African-American men in the 1960s and things we can still continue to struggle with. But again, this push for this radical change kind of helped the deinstitutionalized period continue. President Kennedy in 1963 signed a community mental health centers program, which was to kind of take away the focus of the institution and put treatment on the hands of sort of community treatment centers with the hope on integration back to society. In the 1960s, our nursing home population started to swell. So it went from 470,000 to almost 928,000 in the 1960s, which is nearly twofold growth. So a lot of those folks who were elderly, probably with dementia, were kind of moved towards that model. In the 70s, there was more social and sort of political changes. There was Wyatt versus Stickney, Supreme Court case, where the first standards for institutions were really finally put in place. And those standards just included adequate staffing, humane physical and psychological environment, and individualized treatment plans instead of just treating, large swaths of folks with meds. This led to more deinstitutionalization because that required a lot of price hikes. And the governments began to feel kind of sensitive to the cost of institutionalization, and they started to decrease. Moving people with severe mental illness into the community also meant giving up other things the institution was doing beyond mental health. So food, housing, clothing, those had been the responsibility of the institution, and now we had folks who needed help with those things due to their mental illness. So Social Security income came around in the 70s. Social Security disability income also gave cash support to people with disabilities, including psychiatric disabilities. Also in the 1970s, Section 8 housing became a thing, and fair market rent started to kind of take into effect for our patients. In 1977, I wrote this in red because this was the first time that I think we reached this conclusion that we'll talk about more towards the end, where are we doing enough? And this was a report that said, returning the mentally disabled to the community, the government needs to do more. It highlighted the failure of some of these outpatient clinics to help people with specifically severe mental illness and how we can better support them. So already kind of some ground rumbling about that in the late 1970s. In the 80s, 90s, and 2000s, kind of getting kind of more towards modern time, the Reagan administration in 1981 rescinded the Mental Health Systems Act of 1980. So these community mental health centers weren't mandated by the federal government to treat folks with severe mental illness. So the focus sort of went from our very, very challenging cases to cases that were a little less severe. So these folks with severe mental illness continued to kind of decompensate. There was also the omnibus budget, or there's supposed to be a T in there, but Budget Reconciliation Act of 1981, which sort of bundled these community mental health centers with other federally health programs, and it led to more cuts in spending. So initially, the intention was to kind of help the efficiency of these CMHCs, but due to this deregulation, the efficacy was short-lived, and they were ultimately really defunded. In 1987, there was the McKinney Act, which was a shelter plus program for supportive housing. And then in 1990, the Disabilities Act, which incorporated mental illness into its broad sweep. So employers had to make reasonable accommodations that might permit people with mental illnesses to work. So those are the social political changes, and now we'll kind of move towards the legal changes that kind of occurred with deinstitutionalization. I put a meme in here because it does kind of feel like sometimes we're in kind of language games with our patients about hospitalization and involuntary treatment. So I thought it was kind of humorous because patients feel the same way as providers, and our criteria is sort of like this language we all kind of dance around, and it can be like dodging a bunch of lasers. In 1964, what was our first kind of standard for civil commitment to be established? The first thing they established in 1964 was that before a person could commit somebody against their will to a hospital, they had to have a diagnosis of a mental illness. And secondly, this is kind of the standard still, a person had to pose an imminent risk of threat to their self or others, and they had to be shown to be gravely disabled, meaning that he or she could not provide for the necessities for basic survival in order to be hospitalized. Soon other states followed this model. Interestingly, I included Delaware has an interesting sort of model where the only proof is that a person is not able to make responsible choices about hospitalization or treatment for that person to be committed. And then in Iowa, the only proof is that a person is likely to cause severe emotional injury to people who are unable to avoid contact with the person. So interesting kind of standards. I wonder, I did not check if they're still in practice, but unique to Iowa and Delaware. And then the Supreme Court case of 1975, O'Connor versus Donaldson. Kenneth Donaldson was diagnosed with schizophrenia, and he was in an institution for 15 years, improved on treatment, but held just for having schizophrenia. He did not meet any of the criteria for continued hospitalization, posing a risk to himself or others, or shown to be gravely disabled. So eventually, after 15 years, he was released after hearing. In the 70s, their other rules for hospitalization included psychiatric hold limits. So, putting someone on a psychiatric hold for 2 days to 2 weeks, and different by state to state. And then the right to trial. So when a psychiatrist put someone on a psychiatric hold after that emergency hold finished, they had the right to go to trial for civil commitment, and they were given legal representation. Also included in the 1970s was the least restrictive means principle, which is that when we're assessing patients, we want to make sure we're following that principle, that we're not being restrictive as providers, we're being as the least restrictive possible method of treatment we can give. And then for the hearing for commitment, the burden of proof for a psychiatrist or the hospital to make has to be clear and convincing, which is below the standards of beyond a reasonable doubt, but above the standards of a preponderance of evidence. One of the key historical points that I kind of pulled from this is that research during the 1980s and 1990s showed that people with severe mental illness who live in stable, high-quality housing in neighborhoods with newer housing stock have better clinical outcomes and use fewer health and mental health services than do severely mentally ill people in low-quality living arrangements. Kind of self-explanatory things we probably could assume or know from our experiences. But again, I think this historical point kind of shows, especially in the face of our current issues and the issues we'll get to towards the end of the presentation, that permanent supportive housing and resources are sort of our best bet in helping our patients. So where we are now for New Mexico. So when we're assessing patients for involuntary hospitalization, we have criteria that is similar to the criteria that I was talking about in the 1960s. A person has to pose an imminent risk to themselves or other people. They have to have concerns for grave passive neglect, which is not meeting their activities of daily living, malnutrition, a house that is dangerous and a fire hazard, or difficulty caring for themselves for their medical comorbidities. So meeting those criteria. We have to comport with the least restrictive means principle, and we evaluate people. And then in New Mexico, when we put someone on a hold, it's a 7-day emergency psychiatric hold. So when we place someone on a hold, they are essentially involuntarily admitted to our hospital for 7 days. And this is good and bad. I think that places that have a shorter period of time have less time for treatment. So when we admit people here on a 7-day psychiatric hold, there's an opportunity in a window that's longer than 48 hours where we can move forward with some treatment plans and get a person stabilized before that 7 days is up. And so often a patient may not need to be committed. The 7-day hold provides enough time for us to form a treatment alliance, get on page with the patient, and get treatment and resources. But if a 7-day emergency psychiatric hold gets completed and the patient still needs treatment, we move towards the civil commitment, which is in a court, and we try to commit somebody to our hospital for 30 days or less, depending on when treatment is completed. Or we move towards committing towards something like NMBHI, our state hospital, if a patient is very, very severely mentally ill, which can happen on occasion. Some ethical challenges that we face, as psychiatrists and as providers in the community about bringing someone in for an emergency psychiatric evaluation are, obviously our patients with severe mental illness struggle with distortions of mood, thought, and cognition. And it's the point where it's critical for the safety of the affected person and to others. But that same sort of distortion also impairs a person's insight and judgment. And so refusal of psychiatric care happens very often. As physicians, we're trained under some different tenets kind of governed by Hippocrates. There's non-maleficence, which is to do no harm. There's patient autonomy, and then there's beneficence. So, obviously we don't want any harm to become to the patient, so we have to follow that tenet, but we also have to honor a patient's autonomy. And then we also have to consider the principle of beneficence that, somebody will ultimately benefit from treatment. So we're weighing all of these principles when we evaluate a patient, and those can sometimes be in conflict. Other main principles that underlie the state's interest for civil commitment is the parens patriae that I was talking about, which is the parent of the country. And that's part of English common law, and that assigns the government the responsibility to intervene on behalf of all citizens who cannot act on their own best interest. And then the second legal principle we have is police power, which requires the state to protect the interests of its citizens, and it's a duty to consider the welfare of all people living within the state boundaries. So as providers and psychiatrists, we're always kind of at odds and weighing and battling with these decisions. I included a picture from the movie Repulsion, which is a really interesting movie about a woman who experiences psychosis in the 1960s. And it sort of really gets you sort of in the mindset of what a thought distortion looks like. And it does I think paints a relatively eloquent job of showing what that experience is like. Nuances we face here in New Mexico, we have a lack of psychiatric hospital beds. So our psychiatric facilities include here, University of New Mexico, University Psychiatric Center, Central Desert Behavioral Health here in Albuquerque, Haven Behavioral Health here in Albuquerque, Presbyterian Services, and then the Peak in Santa Teresa, Mesilla Valley in Las Cruces, and then NMBHI, our state-run hospital in Las Vegas. When we have these encounters with folks with these lack of hospital beds, it sort of makes triaging difficult because We need to make sure that we're allotting our beds to the most severely mentally ill folks. University of New Mexico Psychiatric Center, our inpatient units are full of very, very severe mental illness. So if I have a patient who's voluntarily asking for hospitalization, I prefer to refer out, because most of our hospital is full of people who are very decompensated and they're involuntarily, thus kind of making it not a super therapeutic environment for somebody who wants admission. So there are ethical, moral, interesting nuances there about saying, hey, I would think you would probably do better at a different hospital. Things we have to balance. There's the idea of a neuropsychiatric baseline. So we have patients who have chronic suicidality, who come in and say they're suicidal and have been saying they're suicidal for years. And we have to kind of weigh that and think about risk factors and perhaps discharge, if that person does not meet criteria. Some suicidality is a means to get perceived needs because of lack of housing, lack of food resources, lack of security. So we have to kind of make sure that we're treating the folks who need a bed for treatment because of our lack of resources, and balancing when to refer out and when to give out patient resources for that lack of perceived needs. And then there's the idea of like a psychotic baseline, which is that folks with schizophrenia who are perhaps maybe pleasantly psychotic, or they've reached a baseline where they're treated, but they're doing okay. They're not quite sick enough to come in, where they don't have an imminent risk to themselves or others. And how do we balance that? That's also balanced with challenges for psychotic episodes. When a person has a psychotic episode, the return to their cognitive baseline continues to decline. So when do we balance meeting criteria versus protecting somebody's brain? These are all complicated issues. In New Mexico, there's a preponderance of substance use disorders. Can we hospitalize someone against their will for a substance use disorder? Often not, because they're not really meeting that criteria and not really ready to change. And then, beyond that, dealing with the uninsured and the Medicaid in New Mexico, and finding hospitals and places that maybe are privately funded who do not accept patients who are uninsured or have other challenges with meeting the high need here. So lastly, kind of our last kind of objective is kind of, where are we going? What are the consequences of the deinstitutionalized model and the community model? And then what are some of the things that other states have been proposing? So just a couple snippets that I took, that I thought were interesting to kind of talk about the state of our system. The World Health Organization in 2001 said mental illness led to a greater collective disability burden in established market economies than does any other group of illnesses, including cancer and heart disease. In 2003, President Bush's Freedom Commission reported that the mental health system is, quote unquote, in shambles. The report described excessive disability, homelessness, dependence on social programs, school failure, and incarcerations in jails and prison. 30% of homeless single adults have a serious mental illness, as do a disproportionate share of those in our jails and prisons. And then kind of dealing with the issue that while in the public, sort of in the abstract, is optimistic about treating mental illness, on a personal level, members of the public wish to keep their distance. And that challenges our ability to house and put folks in safe and good neighborhoods when they struggle with severe mental illness. In general, sort of over the last 60 years, we can kind of summarize that the United States has transformed its mental health delivery from sort of a centralized planned activity run by the states to a pluralistic market-oriented system of care. And the consequences have been to exchange a set of bureaucratic failures and tight budgets in the institutions that took a large responsibility for a circumscribed population, to a very rich, decentralized system of care that suffers from market failure and allows some people with significant impairments to fall through the cracks. More consequences of us moving towards this dangerousness criteria is because hospitalization is often a first person's interaction with the psychiatric system. The shift towards this criteria, this dangerousness criteria, has led to a compromised ability of mental health care to individuals with mental illness who are refusing treatment. We don't really intervene until a person becomes a threat to themselves or others, or fails to perform their ADLs. And, this can cause a huge gap in care. Through interviews with mothers of folks with mental illness, this author, Copeland, interviewed a large swath of folks and found that mothers who have children with mental illness and that current civil commitment criteria forces them to watch their loved ones kind of go through the progressive stages of psychiatric decompensation before they can get any help at all. And that's true when we think about first break, and as I was talking about with psychosis and returning to mental baselines and weighing, mental cognitive challenges versus admitting to a bed when the patient isn't quite severe enough. So again, more challenges for our state. Obviously, the worsening of people experiencing homelessness, suffering from severe mental illness, since deinstitutionalization and change in commitment standards towards dangerousness, there's been a large increase to our inmate and criminal justice population. So U.S. inmates, 10 to 25% have a mental illness diagnosis. Many of these mentally ill inmates are nonviolent offenders, a fair number of who are convicted for survival crimes like theft of food, or trespassing for shelter. And then this is usually related to their limitations in social functioning and ability to meet their basic needs because of their chronic mental illness. And then also, it's found that people who are civilly committed in the past have a higher likelihood of arrest than people with a history of a voluntary admission. Interestingly, through this article Tessa and West put out recently, talking to police from nationally, one reason police cite as a motivating factor for taking people with mental disorders instead of the psychiatric facility to the into criminal custody rather than the hospital emergency rooms is that the justice system is a more likely route through which long-term care can be achieved. And that's unfortunate, but that is a direct result of the decreased average length of involuntary hospitalizations that's occurred because of the shift to the dangerousness criteria for civil commitment. Involuntary hospitalization has become a quick and limited fix for acute and severe mental pathology rather than a step toward long-term psychiatric care. And then balancing this role as mental health providers and providers in the community is, when is the practice of psychiatry practice in medicine or a force of social control? And balancing those issues. This was a policy proposed due to large populations of homelessness in New York City. So in November of 2022, New York City Mayor Eric Adams made a directive to first responders, including police officers, paramedics, and outreach workers, instructing them to involuntarily transport individuals with mental illness who are experiencing homelessness to hospitals if they present a risk of harm to themselves or others, which is something we do. But in that, he also lowered the standards to remove an individual from the street or subway if he or she appears unable to, quote, meet basic living needs, even when no recent dangerous acts have been observed. And so, asking the group and to kind of think in your heads about this, like, what would some of the challenges be if that was a directive that was sent to us as providers? And how would that work? How would a population respond? What moral, ethical issues would we face taking folks to hospital for seeming mental illness? And then, is that a fix? Is that something that we can deal with? And so the APA, the American Psychiatric Association, responded to this directive. Michael Hogan, a PhD of Case Western Reserve University School of Medicine, said that this policy undermines policies in place to decriminalize mental illness, like the suicide hotline. It forces first responders to traumatically enforce policy against patients' wills. And most specifically, it does not address the aftercare issues we've been discussing: housing, treatment support, wraparound services, and the value of hospitalization is really only fleeting and temporary. Nick Kerman, another person from the Center for Addiction and Mental Health Services in Toronto, said, quote, "We believe that New York City's policy approach is a violation of human rights. It harms the personhood of people with mental illnesses experiencing homelessness, and that this policy will have deleterious effects on this population, mental health services, and evidence-based interventions for homelessness." They broke it down kind of into 3 tenets. It said it perpetuates structural stigma in assuming people with mental illnesses experiencing homelessness cannot care for themselves and need to be hospitalized for theirs and others' safety. It overlooks why people with mental illness are living on the streets and not in shelters, and doesn't address our concerns about the safety of our emergency shelters, which I can think of 5 or 6 patients I've seen in the last month who have told me they feel uncomfortable at our shelters here in Albuquerque. It burdens mental health systems that become tasked with addressing the housing and shelter needs of those admitted to the hospital. So folks are admitted to on an involuntary hospitalization, and we're addressing kind of the housing and shelter needs as opposed to the mental health diagnoses. And that can be challenging for providers on the inpatient setting as well. You know, I took this quote from JFK, who did the Community Health Centers initiative in the 60s. This is something he said in 1963, and I still think kind of holds true to what our goals should be. He said, "We must act to bestow the full benefit." I'm sorry, I may move my screen. The full benefits of our society to those who suffer from mental disabilities, to prevent occurrence of mental illness wherever and whenever possible, to provide for early diagnosis and continuous care in the community of those suffering from those disorders, to reorient our programs to a community-centered approach, to reduce over a number of years by hundreds of thousands the persons confined to these institutions, to retain in and return to the community population with mental illness, and there to restore and revitalize their lives through better health programs and strengthened educational and rehabilitation services. And, you know, kind of to sort of summarize and think about these challenges is, I think we have a unique opportunity as psychiatrists, providers in the community to mobilize. We can advocate for more permanent supportive housing. We can advocate for institutional support, and we can advocate for inclusive low barrier outpatient services. I think we're in this sort of middle ground where we've moved from the deinstitutionalization model to community health resources, which have been good and helpful. But I think that in that we were kind of in this halfway point where our community health resources aren't funded and aren't low barrier enough for us to treat patients. And then these folks with severe mental illnesses fall through the cracks. So I think there's a middle ground here that needs pushing, and I think that together we can do it. So that would be kind of my conclusion. That kind of summarizes sort of my thoughts on that. Please let me know if you have any questions or any thoughts on how we think about these folks and what we do for our patients experiencing severe mental illness and how we can help in Albuquerque. That's it. Thank you so much.
Thank you so much for this wonderful, thought-provoking presentation. I will be still here for any questions. Feel free to unmute yourself if you have any question.
Hi, Dr. Kloster. Thank you for this presentation. Very important and complicated subject. Somewhat related, in New Mexico is the process of certificate for evaluation, which is not the same as an involuntary hold, but is maybe a first step for some patients in getting involuntary mental health treatment. But in the community, I see the two being kind of mixed up and conflated. You know, the term C4E being called an involuntary hold when maybe that's not what it's meant to be. It's meant to be something that brings a patient who needs an emergency evaluation to get evaluated. And I know you're a psychiatrist, so you can't give legal advice necessarily, but in general, I work for an institution where the emergency department is filing a C4E on patients who need an involuntary psychiatric hospitalization. Is that the right thing to be doing? Or in your experience, should those patients get placed on an involuntary hold instead?
Yeah. So are they filing a C4E like after discharge from the emergency department?
Sorry, no. So if someone one way or the other ends up in the emergency room for a mental health crisis and they are in immediate danger to themselves or others, but they're not agreeing to go to a psychiatric hospital, the emergency room attending files a C4E
Yeah.
and calls it a hold.
Yeah. So I think those two do get conflated. And so a C4E, especially like in a hospital that may not have a staff psychiatrist, the C4E is essentially the transfer for evaluation by a psychiatric provider to determine if a patient should be admitted to the psychiatric hospital. So my understanding is that a psychiatrist has to sort of make that assessment. So the way it works at University of New Mexico is that we have our psychiatric emergency services, and we have a list of like running C4Es in the community. And C4Es are essentially sort of the same criteria as our involuntary admission standards. Danger to themselves or others, concern for grave passive neglect. My personal opinion of a C4E is that it should also be low barrier. I think that more C4Es are probably better, because I think that we have, like in this presentation, we have this population of folks with severe mental illness who are refusing treatment and doing poorly. And they may get an evaluation by a psychiatrist at that point from a community person, whomever is filing the C4E, and may not meet criteria at that moment for a hospitalization. They may have methamphetamine in their system, and PES sort of operates as a sort of a metabolization center sometimes. I have folks who come in and they're very psychotic on meth, and they'll clear and they'll ask for discharge. And so we use PES as sort of a holding ground almost to kind of see the longevity of that situation and then make our decision. So C4Es, there are times where I've discharged C4Es and there's times when I've admitted C4Es. So I think in terms of filing C4Es in the community, it should be, low barrier, I think. But also considering that there should be some criteria met. That criteria is there for a reason, and we need to honor the autonomy of our patients. But I think that having a patient get more interaction with the psychiatric facilities and psychiatrists and moving towards mental health treatment is probably best. And so I think that we conflate, and back to the point of your question too, I think in the emergency department and in, other hospitals where we say you're on a psychiatric hold, typically not a psychiatric hold until a psychiatrist makes that psychiatric hold decision. It's more, you're on a hold for a C4E until we can get you seen by a psychiatrist.
Okay, thank you.
I can see a chat in the chat box. It's mentioned we definitely need more resources for patients coming out of acute care. Yeah, of course. And if anybody have any other question, please feel free to unmute.
No, I think that's a great point. And I think that's sort of where I've come down on this whole exploration. I think there's pushback between, I think, our psychiatric facilities and our community providers, because our community providers are bringing a lot of people in that they see in the home, and we're not at the home, right? We are in the emergency department, we're in psychiatric emergency services, and we're making our assessments, and things can look different on the ground. So it can be discouraging sometimes, I think, for community people to bring patients to the emergency department and see that they're discharged. But I also think there's a misunderstanding too of what an inpatient psychiatric hospitalization does. We look at New York City, right, and the idea that seemingly to have this quick fix for what the mayor is seeing as rampant homelessness and severe mental illness is inpatient psychiatric hospitalization. That may or may not be the answer in a lot of cases, and usually it's typically not. It's more towards getting these folks these intensive outpatient services and supportive community housing, and that's something we need to continue to advocate for here in Albuquerque. You know, it's tough, and our lack of housing definitely shows, and we discharge folks probably back into communities that are challenging and ripe for psychiatric decompensation due to violence and drug use. So continuing to push for those things, I think, is super important. Back to your point.
Thank you once again, Dr. Kloster, for your presentation. And thank you everybody for joining us today. I am right. Okay, I can see another raised hand.
Hi, Dr. Kloster. I just had a question about transportation. Through our ED, we have a very difficult time finding transportation once somebody has been psychiatrically accepted for placement. Do you have any guidance or recommendations, or have you seen other rural communities, like what maybe they've done to assist with this challenge in hospitalization?
Yeah, absolutely. That's a great question. Unfortunately, I have not, Elise, I have not seen how folks are doing it. I know in our PES, or our psychiatric emergency services, since we have, you know, these different hospitals, not a whole lot of mental health hospitals, but transporting from our emergency services, the psychiatric facility, to these hospitals, our nurses reach out to, I'm sure you have all the different transport companies, but I feel like they're always calling. Besides like being persistent and kind of pushy, I feel like that's how they do it, is they're throwing out as many lines as possible. And even when we've accrued transportation, we're still looking for others that may come faster or sooner. So I think, you know, throwing out lines and seeing whom can transport. I know there's a lot of different companies and providers of that, but I'm actually not sure what a good way of doing it is. They may be better at answering that question. But I think what I've seen and what I've observed of our staff is that the more lines out, the better.
Okay, thank you.
I have a quick question. If we have individuals that we see come through our hospital or even our outpatient clinic with severe mental illness, and of course they go over to acute treatment and then they get discharged back to the community, but these are individuals that could potentially benefit from a treatment guardian. Is that something that the acute hospitals address or look at? Previously, when I worked at NMBHI, that was something that was more prevalent, and I'm not sure if that was just a NMBHI thing because of, you know, the patients with the severe mental illness that are seen there, or if that's something that all of the different hospitals and facilities consider, or if there's some type of process for those individuals.
Yeah, that's a great question. It should be something that every psychiatric facility is doing. You know, when we hospitalize somebody, and this is not PES, so this is not our emergency department. So if in the emergency department we let someone observe or metabolize a substance and they clear and they're not meeting criteria anymore, we would discharge. But if we admit to our hospital and a person has severe mental illness, we assess the need for a treatment guardian. And a treatment guardian is going to be somebody who makes psychiatric decisions for a patient. And it's if a patient does not have the capacity or the understanding to understand their mental health diagnosis and the consequences of that, and then to also not understand the medications and the reasons for the treatment of their medications. And so it happens often. I think treatment guardians are one of our steps in pushing our giant boulder of responsibility for this population to get on the right track. I think advocating for treatment guardians is super important. And so the treatment guardian process would also be a legal process where a psychiatrist would make a pitch to a judge or the commissioner, and the patient's allotted representation if he or she disagrees, and then we establish a treatment guardian, and those can be for 6 to 12 months. And so that person is really a benefit to community providers and to folks. If they see a treatment guardian if they mention a treatment guardian, if you see it on their EMR, give that person a phone call, because that person should legally be in contact with that person weekly, should be managing and changing their psychiatric medications that you would not need the permission of the patient to do. They would give you a really in-depth psychiatric history because they would know the person. We have treatment guardians who are family, and then we have treatment guardians who are through organizations like the Honor Guardians is something I know here in New Mexico, which is a company that allots essentially a guardian to a patient. And that can be really beneficial because of, I think, sometimes the dynamics that occur within a family when your dad is forcing you to take treatment against your will. Yes, treatment guardians, very important. I think pushes us towards this outpatient supportive model that still needs a lot more institutional support, but an important step, I think, in psychiatric stability.
Doctor, if I may just have a follow-up to that question. If I understand you correctly, you said that the psychiatric facility should be assessing to see if a treatment guardian is needed. Is that, and I often understand that that is a process that goes through the legal system. Is that something that the psychiatric facility has the ability to begin that process through the court system?
Yeah, absolutely.
Okay.
So it happens while they're hospitalized. So, assessing capacity to understand medications is like part of the hospitalization process. And then if I feel that that person does not understand their diagnoses or their medications, I file with the court, and we go to court while they're in the hospital.
So essentially, if that has been determined, then that patient would not or should not be released from psychiatric placement until there is a legal document assigning that treatment guardian.
Yeah, absolutely. You can do it on an outpatient basis. I'm less familiar with that in my training. I'll do more of that next year. But I know that process can be a little more arduous and time consuming, and you have to get somebody to come to the hearing, and somebody with severe mental illness who is meeting that criteria is going to be hard and challenging to do. So involuntary hospitalization or psychiatric hospitalization, even voluntary, if a patient meets that criteria, it's a really nice opportunity to rapidly address that.
Thank you.
Okay, we are almost done. I'm guessing almost done. And thank you once again to everybody. And the conversations were really good. So yeah, thank you for joining us. I'm ending the presentation now.
Thank you.
Thanks, you all.